So now we'll go into the pathophysiology of this group 1 pulmonary arterial hypertension. This pulmonary arterial hypertension previously it was called as the primary pulmonary hypertension, then it was called as idiopathic pulmonary hypertension. And here we have two varieties, the hereditary form and an acquired form. The hereditary form accounts around 85%, the rest of the 10 to 15% will be an acquired form. So here on the left side, you have a normal pulmonary artery. You can see 3 layers. Center on red color is the blood. And the 3 layers are the tunica intima, the media, and the adventitia. And what happens in pulmonary artery hypertension is that you have a lot of triggers like hypoxia or shear stress or some sort of inflammation. And these people have a substrate of genetic predisposition. So when you have a substrate and another trigger onto that, then it induces a lot of chemicals there. So these chemicals or some changes in the internal milieu within the endothelium of the pulmonary vasculature leads to intimal proliferation, medial proliferation, smooth muscle, increase in the smooth muscles. So all these things leads into the thickening of the media and the intima, so that by reducing the radius of the pulmonary artery. So you can see in the right side where you have the pulmonary hypertension patients with a smaller radius, internal radius of the vessel and a thickened media and intima. So this now, if you recall the equations, so when the radius is reduced and even the vasodilatory mechanisms at fault. So because these patients have a lot of vasoconstrictive chemicals. So when the vasodilatory mechanisms fault, you have a smaller radius of the vessel, which leads to increased resistance in the pulmonary artery. So that leads to pulmonary hypertension. So now eventually it leads to a pressure overload on the right ventricle. So now the law of Laplace come into play, which already I told you. So now the according to law of Laplace, when there's a pressure overload, you have hypertrophy. That means cardiomyocyte size increase. And the RV wall stress also increases. And stress, when there's an increase in the stress, the oxygen demand to the musculature increases. And eventually it leads to RV failure. And that is the last stage of the pulmonary hypertension. Now coming to the treatment. Now, traditionally we were talking about these important 3 pathways: the endothelial pathway, the nitric oxide pathway, and the prostacyclin pathway. Prostacyclin pathway deals with the arachidonic acid metabolism and the prostacyclins. Whereas the nitric oxide pathway deals with the L-arginine metabolism, and the endothelial pathways, you have endothelins. So all these endothelins do have vasoconstrictive property, and they increase the vascular proliferation. So what we can do is we can block these endothelin receptors. You have 2 types of receptors: endothelin receptor type A and type B. So when you block these, the proliferation to some extent. When you target coming to the nitric oxide pathway, these nitric oxide pathways are helpful because they have vasodilatory property and anti-proliferative property. In patients with pulmonary hypertension, this pathway is at fault. So they don't have sufficient amount of nitric oxide. So the beneficial effect of vasodilation is not there. And the prostacyclin pathway, again, the pathway is good for the vasculature because the prostacyclins have vasodilatory and anti-proliferative property. But when these are at fault, then you have pulmonary hypertension. So we can target these 3 pathways for our treatment. So coming to the molecular targets, whatever the treatments we have. So the first group what I have put is the endothelin receptor blockers, ambrisentan. Ambrisentan is a selective blocker which blocks the type 1 receptors. And bosentan, macitentan are non-selective. They can act on both the receptors, endothelin receptors. Then you have the phosphodiesterase enzyme 5 inhibitors, namely the sildenafil and tadalafil. Sildenafil is short-acting, whereas tadalafil is a long-acting one, where the action is prolonged for more than 24 hours. Then you have the soluble guanylate cyclase stimulators. So the drug will be a Rio-C-GOT, and this also has been studied in some of the trials. They can also, these act on the nitric oxide pathway because they increase the cyclic GMP, and then thereby they increase the vasodilatory and the anti-proliferatory mechanism. And you can use prostacyclin analogs because you don't have sufficient prostacyclins because of the defective pathway. So epoprostinol, eprostinol, iloprost are all the molecules that has been used in these conditions. And you have one more agonist, a non-prostanoid agonist, Celexipac, that has also been studied in some of the trials. So these are the drugs as of now we have. And the problem with these drugs, as it happens, some of these drugs have their own adverse effects. So we should be aware of those adverse effects, mainly in patients who receive endothelin receptor antagonist. You should always check for anemia in your follow-up and look for the liver function test in the follow-up. And these patients sometimes have fluid retention also. So these patients, when they have a RV failure, RV dysfunction, already they will be having a fluid overload, and added on to this can add on to the fluid retention. So those things you have to look into, have it in the mind when you have a patient on these endothelin receptor blockers. And patients who are pregnant or patients who come to you in the childbearing age, always screen for pregnancy test because these drugs are embryotoxic. And then coming to the phosphodiesterase inhibitors, because they produce vasodilatation. The most commonly encountered side effect are being nasal congestion because of the vasodilatation of the nasal mucosa. And then they can have headache, migraine-like headache, and then they can have gastroesophageal reflux disorders. All these are related to the vasodilatory properties of this drug. And PPS, yes, you can have jaw pain. So that is the most common thing. You have jaw pain, and bone pains are also reported. And you have to always look for the line infection because some of the drugs are given intravenously. So they can have line infection and side pain. And most of the time you get calls for side pain, IV side pain or subcutaneous side pain. And with regard to the inhalational route of administration of these PPAs, you can have cough. And the other drug, it is a soluble guanylate cyclic stimulants. You can have most common effect is the hypotension, and then they are also embryotoxic. So what is the evolving treatment paradigm is in 2023. Previously, in the past, when we did not have much of the drugs, so we used to have a single drug. So that most commonly we use sildenafil. In those times when we were using mostly depending on calcium channel blockers. So we used to add one drug, and if the patient does not respond, then you choose another drug. Then even if there is no response in the follow-up, then you keep on adding the drug. So then this is a sequential combination what we were doing initially. And there were now questions regarding whether you can do an upfront combination in the starting itself, whether you can start with one drug or even more than one drug. So at least in high-risk patients, probably we may have to use 2 to 3 drugs as an upfront combination because it might have an impact on the outcomes. So do we have any evidence? Yes, we have some evidence. So there comes the Triton trial for the role of triple therapy. So here what they did is they have used 2 arms. So they have selected around 250 patients and they were divided into 2 arms. For one group, they have given 3 drugs. The other group, they have been given only 2 drugs along with the placebo. So the drugs that they have used is macitentan, tadalafil, and Celexipac, which is an analog, prostaglandin analog. So these 3 drugs were given in one group of patients. The other group were given only macitentan, the bosentan. Macitentan is an endothelin receptor blocker, and tadalafil is a phosphodiesterase inhibitor, and the other one is a placebo. It was a double-blinded study, a randomized control study. And if you look at the result of this study, the primary outcome what they were looking at was the change in the pulmonary vascular resistance at 26 weeks of therapy. So what they found that there was some more than 50% reduction in the pulmonary vascular resistance, but it was same in both the arms. So there was not much difference between two arms. So the primary endpoint was not reached because there was no change, there was no difference between two arms. But 2 drug and 3 drug, both had the same effect, almost the same effect. And the secondary endpoints they checked mainly was the 6-minute walk test. And the another one is the NT-proBNP level. So here also, if you see, there was not much difference between both the groups. Almost 50-meter difference was there between both the groups. So there was not much difference between the two groups, whether you start on the 3 drugs or 2 drugs. But then there was some exploratory analysis because scientifically you should be very carefully look at this data because the primary endpoint was not reached because there was no difference. But when you look at the exploratory analysis, there was a trend that patients who received triple therapy, the event-free rate was a little better with the triple therapy group. So maybe, probably, in the future, we may have more data that triple therapy may have better outcomes. So at least in high-risk patients, sometimes we may have to choose or start them on 3 drugs. And your follow-up, you have to make some risk assessment model or even in the initial visit. So the most commonly used things are mostly subjective. So you look at the function class of the patient or the symptoms of the patients. So that is one thing which is seen in all the models. And 6-minute walk test is a very important test, and very simple test, a non-invasive test, which can be done easily by anybody, even in a very rural setup. These 2 things can be done. So what you do in a 6-minute walk test, you ask the patient to walk for 6 minutes at their own pace. So they can even take rest, or they can stop in between. Only thing, you should have a place to walk. You should know how much the distance is. And then at the end of 6 minutes, you have to see how much meters they have walked. So based on that, you can make a risk assessment of these patients. And in some model, we use the right atrial pressure and cardiac index. And the other 3 models also use the NT-proBNP levels. This now it is easily available. It is available in most of the places. So NT-proBNP levels, now you have, it is now even a point of care testing. So you can do it on the bedside. The result will be within the 10 minutes. So based on that, you can make a risk assessment. In, the other things are all invasive tests, right atrial pressure, cardiac index, and the mixed venous oxygen saturation. So what are the risk categories? You can categorize these patients into 3 categories: a low risk category, high risk category, and intermediate risk category. How do we categorize? Because it is based on the estimated 1-year mortality. Suppose the estimated 1-year mortality is more than 20%, then they come under or fall under high risk category. If the 1-year mortality is between 5 to 20%, then it is intermediate risk category. If the 1-year mortality is less than 5%, they are a low risk. So there are a lot of parameters that has been used to categorize these patients into one of these 3 categories. So the important thing I have highlighted in white, the boxes are highlighted in white, which is easily available. As I said, echocardiogram, proBNP levels. And then the other things are all non-invasive, mostly based on subjective information from the patient. Signs of right heart failure, progression of symptoms of pulmonary hypertension, syncope, presence or absence of syncope, and then WHO function classification, and the 6-minute walk test. If you have a 6-minute walk test of less than 165 meters, yes, definitely they are coming in the high risk category. And these patients will have repeated episodes of syncope. Syncope, if you have a patient with pulmonary hypertension, repeated episodes of syncope, then they are all at a very bad prognosis. And these patients have a very rapid progression of pulmonary hypertension, and they go into right heart failure very easily. And the other tests are not used in many centers. Cardiopulmonary exercise test, Then cardiac MRI is sometimes we use, but not routinely. And then hemodynamics is not routinely used by all the places because you need a cath lab and a cardiologist who will be capable of doing right heart catheterization. So based on these things, we can categorize these patients into 3 categories. Now, what is the treatment goal? The treatment goal is not only to keep the patient or stable in one. I've shown you what was our treatment goal. Treatment goal is to make the patient to come down to the green side. That is, any patient who are on high risk has to come to the intermediate risk, or any patients who are on the intermediate risk has to come to the low risk group. That is our one of the treatment aims. To achieve this, we can either increase the dose of the current drug, or you can add a second agent or even a third agent. And it can also be achieved by switching one drug from one group to another group also. So this is how we have to manage. Okay, currently approved pulmonary arterial hypertension therapies, which act via these traditional pathways, namely the prostacyclin, endothelial, or nitric acid pathway. We have targeted these 3 pathways, and we have a good number of drugs. But still, is everything good? So, no, if you look at the data, still these patients still remain with the prognosis, with the poor prognosis, and even the estimated 5-year survival, 5 to 7 year survival is approximately 50% after the diagnosis. So they do not achieve the low risk status, and they do not meet treatment goals. Still, they remain in the poor long-term prognosis. So what could be the reason? So we need to have some other newer therapies. So we have to identify some newer targets, molecular targets, and find out the newer therapies. So now there are a lot of molecular targets that has been postulated. I have not put everything here. It's really confusing. But one of the most important pathway now, the upcoming pathway is this pathway. This is a bone morphogenetic protein receptor 2 pathway. So here you have 2 arms. The one is the anti-proliferative arm. The other one is the pro-proliferative arm. In the anti-proliferative form, you have the BMPs, that is the bone morphogenetic proteins. So they act via the BMPR receptor 2. So this is on one side. The other side, you have the activins. Activins are another molecules or proteins. They act through the activin receptor 2A or B receptors. So these activin receptors, when they get activated through these activins, it results in the formation of some SMAD proteins. These SMAD proteins, in turn, leads to the production of gremlin and noggin proteins. So these proteins, through BMP molecules, through BMP receptor, they act, and they makes an inhibitory action on the pro-proliferative pathway. So that means the balance is maintained between the pro-proliferative and the anti-proliferative pathway. But in patients with idiopathic pulmonary hypertension or the group 1 pulmonary hypertension, the problem is they have a defective in the gene of the BMPR receptor 2 molecules. So they have a defective receptor. So when they have a defective receptor, the anti-proliferative mechanism is not operating. So you have a dominance of the pro-proliferative pathway through the activin molecules, and that results in proliferation of the cellular matrix. So this leads to excessive deposition of the tunica media and intima, leads to pulmonary arterial hypertension. So they have identified this as one of the molecular target, where when you block the activins now, if you block the activins, so you don't get sufficient activins to the activin receptors. So thereby the proliferative pathway will not be active. So thereby bringing the balance back to normal. So the molecule studied has been Sotatercept. Actually, Sotatercept is a fusion protein which binds to the activin receptors. So by binding it to these receptors, the balance is shifted to normal, or if the balance is restored. And these proteins, actually, as I said, one is the anti-proliferative proteins, the other one is the pro-proliferative pathway. So, but thereby it reverses the pulmonary arterial wall and RV remodeling in preclinical models. So, the phase 2 trial was done with the trial was PULSAR, and they have shown that these patients had reduction in the pulmonary vascular resistance. Then in the STELLAR, that is the phase 3 trial that I will be showing in the next slide. The side effect of these drugs are most commonly thrombocytopenia, and these patients do have increased hemoglobin levels and some bleeding tendencies also, and some reports of telangiectasia were also reported. Now coming to this, the Sotatercept binds to the activin molecules there. So as I said earlier, so that pathway is also inhibited. So already this anti-proliferative pathway is a defect. So now it is balanced. So that is the idea of using this molecule. Now this STELLAR trial is a randomized double-blind phase 3 trial where this molecule Sotatercept was added to patients who are already on a background therapy for pulmonary hypertension, either on 2 or 3 drugs, but stable patients, and patients who were on function class 2 or 3. So what they found, what the aim of the study was to find out the 6-minute walk test at 24 weeks. So that was the primary endpoint. But yes, the trial showed a meaningful improvement in 6-minute walk test at 24 weeks. And it also, there was an improvement in the BMP level also. It's typed wrongly. So BMP level also, anti-pro-BNP level also was had a very significant improvement. Other secondary endpoints were checked. So the means, you can see the diagram or the graph showing the change from the baseline for the 6-minute walk test over a period of 24 weeks. And the probability of even-free survival based on a Kaplan-Meier survival curve, the drug also showed a better prognosis when compared to placebo group. So that's with the drug therapy with the pulmonary hypertension. And the other therapies that has been newly coming up is one is the pulmonary artery denervation, which is a catheter-based therapy where you identify the place where the afferent and different neuronals are being supplied to the pulmonary artery. And it is through the catheter, we do some ablation. So this is done for patients who do not respond to all the drug therapies. And sometimes some patients has to undergo atrial septostomy when the right side pressures are very high. That is only a palliative treatment. They do not have a very good result, but that's only a palliative. That is atrial septostomy, which is done only for patients with severe pulmonary arterial hypertension. Okay, thank you.